We've got a nice packed agenda today. So we've just got a few updates from previous meetings to catch up on. We've got an interesting couple of Jamboard exercises to get some interactive elements going. We've got Jo Wookey, who some of you may know, who's a senior program manager here at the AHSN. She's going to talk about what's happening with virtual wards nationally and more locally. Then we've got a video from Professor John Hurst about NACAP and the discharge bundle work more generally. And then we'll just have a quick word about the future of the programme. So if I just kick off with the updates from previous meetings. I just wanted to put this on because there are a few things that we've raised in previous meetings and then not come back to. So I just wanted to make sure we didn't leave loose ends undone. We talked about the case ascertainment project a couple of meetings ago about the potential for a piece of work just to look at services where there seemed to be a lot of COPD and asthma cases falling under the radar that weren't being captured by the audit. And I had a couple of conversations with some of the specialist nurses in a few of our big services. And after those conversations, really, we reached two conclusions. So one was where there is a low ascertainment rate, people tend to know what's going on locally in their own services. And if you disagree with this, please feel free to put something in the chat and we can address that. But there are all sorts of examples like notes being taken off to different places for discharge summaries, about the challenges of trying to get people to change coding after somebody's been admitted for another reason, various factors contributing to that. So it wasn't one of those areas where people didn't know why they had a low case ascertainment. So that was number one. Number two was at the point where we're having those conversations, which was in the run up to Christmas, the services were just under so much pressure that nobody felt it would be a good use of time to focus on that. And if you remember, we just had the Omicron variant emerging at that time, so people really were under pressure. So that was one item. The other item I just wanted to address was about the patient data opt-out. So we said a few meetings ago that there was a national opt-out for people that would have an impact on the NACAP audit in the sense that they could choose for their data not to be used for this audit, and trusts would need to build in a step into that process to make sure that they were excluded. That was delayed from last March until September. And we didn't actually feed back that it was then delayed again from September to the 31st of March this year. So the plan from NHS Digital is that that national opt-out will be applied from the 1st of April 2022. And hopefully people who are managing the audit data collection and the submission process are aware of that. But I would just reiterate, as we did last time, that it would be helpful to have conversations with them just to make sure, because this won't just affect NACAP, this will affect all the audits people are involved with where they have to submit data. So that's it from me. I was going to hand over to Tom just to give an update on the data dashboard.
Yeah, thank you, Sean. Sean, can you see my screen? Real. So thank you all for just having me quickly talk you through the dashboard today. I know for the past few meetings we've been saying, oh, we're working up the data agreements, we're working up getting hold of the data, and the good news is that we have now actually got an updated data set up to the end of December. And so for those of you who access the dashboard slightly more frequently, hopefully you may have seen this already, but for those of you who don't, yes, we have now got data for COPD up to December. And so what we're just looking at the moment is, from my development view, the blue area chart is the KSS average, and then the darker blue line is your national average. And so what we can see from this is that we've got areas such as accessing PR, which remains strong versus the national average. And again, this is nice to see with our really busy PR network. We continue to be above the national average for measures such as the emergency drug pack provided. But yes, I would encourage anybody to go away and have a look at this dashboard once again and to review where their trust is. What's always been a shame with this dashboard is that it hasn't quite the national audit data set doesn't go back far enough to show the improvement journey that KSS trusts have kind of been on since 2016 almost. Whereas we were only able to show back from was sort of November 2018 time. But nonetheless, there's some really interesting information in here. One thing I'll also highlight to those who are slightly more familiar with the dashboard is that the latest data set came through to us, and we're now able to filter that data down to a hospital level, which is particularly important with the merging of sort of Brighton and Western hospitals into that almighty super trust, University Hospital Sussex. So you can now filter down to a specific hospital, which will be hopefully really helpful for those of you who've got quite dependent or independent services despite being within the same trust. So that's everything on the COPD dashboard. Similarly, we've been working away trying to get hold of the asthma data, and the good news is that we have now got the asthma discharge bundle data accessible as well. This hasn't yet been published to the dashboard because I've just been working away, just trying to make sure that everything's adding up correctly and working nicely. But this is sort of a first view of the asthma dashboard. Very similar. Quite a lot of the measures do overlap with that of the COPD discharge bundle. But we have got some measures such as the personalised asthma action plan, which isn't part of the COPD discharge bundle, of course. And obviously, asthma is a new field for the AHSN in the quality improvement programs, and so seeing this data for the first time has been generally quite interesting. And again, it's nice to see that we do follow a lot of the national averages. There are areas where we can continue to sort of focus on, and again, something like the appropriate follow-up, which we've always tended to be slightly behind the national average for in COPD. It looks like we've got a very similar sort of trend within the asthma data set as well. So please go away and have a look at this asthma dashboard as well. It's all wrapped up in the same tool, and there'll be a note out when it's all available. The only thing I'd flag with the asthma dataset is that there are far fewer patients recorded in the audit compared to the COPD audit. And that does mean that when you're starting to filter down to a trust level or down to a hospital level, you'll be finding that a lot of your data will be coming through at 0%. And this is purely because of small number suppression. And again, for anybody who's not quite familiar with this, any sort of total on the dashboard, which has got a sum of fewer than 5 patients sat behind it, I have to suppress that data point down to 0% just to ensure that we can't identify those patients. And so what you might find is that a lot of your data will be reading at 0%, and unfortunately there's just not too much we can do about that. But for as bigger services, it might be that you've got some slightly more intelligent charts that will be able to show you your adherence to each of the measures. But yes, hopefully a bit of good news for those who've been interested in the asthma data. As I say, we've been trying to get hold of this for a while now, and fortunately it came through beginning of last month and will be accessible for all to start accessing on the dashboard shortly. Are there any questions? Nope. Brilliant. As ever, if anybody's got any questions that would rather just email to me, then please do, and we'll try and then pick those up with you on a one-to-one basis. Great. Thank you, Sean.
Okay, thanks, Tom. So just a moment if anybody's got any questions or comments on the dashboard. Okay, so for our next trick, we're going to try something we've not done before in this group, and that is to try and use Jamboard. In the meantime, I will introduce Jo Wookey, who's a Senior Programme Manager here at the AHSN, and she is currently working on virtual wards across Kent, Surrey and Sussex. Jo, I'll hand over to you.
Oh, right, let me see if I can share my screen. Hello all, nice, thank you for having me, nice to be here. I'm just going to see if I can. Oh, it's going to do this in a really difficult way because I've come in on the wrong thing. Bear with me a second. Let me see if I can just. I'm just finding the right presentation. Where am I? There we go. And I'll try and put this onto slideshow. Right, hopefully everyone can see that. So do ask questions as we go. So I'm Jo Wookie. As Sean says, I'm one of the senior programme managers at the Sussex Academic Health Stats Network. Previously been involved in supporting managing deterioration, and I'm currently trying to support virtual wards and the development of virtual wards across Kent, Surrey and Sussex. Some of you may also know me as I've formerly been involved in the respiratory work at the AHSN, and I'm a respiratory physio by background. So really what I'm going to do is, hopefully some of you may have already been involved in local discussions around virtual wards, but just to give you a bit of an overview of national position, where we are and what's the sort of discussions that are happening locally really. So I think obviously during the pandemic, actually, let me just go back. So really, I would say I think virtual wards isn't a new concept. I think there's been various hospital at home and virtual wards have been set up for a number of years now for varying different conditions. Obviously, the term means different things to different people depending on the services that they're running. So they're still trying to work through some of the definitions of exactly what we're talking about in terms of respiratory and frailty, which I'll come on to a second. The other push for this really is about expanding existing virtual wards, and that includes some of the COVID virtual wards that were set up to help manage during the various waves of COVID that we've had and are in place across the entire patch. So it's really taking some of that learning, how it can support the system. We know it helps to support patient outcomes, the shared decision making, improving patient flow, decreasing length of stay, increasing capacity to help manage huge volumes through the hospital. So there's lots of benefits to the virtual ward. And as you can see from this slide, hopefully, actually, let me just put that down in case you've got a box that's covering the map, that there are already existing virtual wards in place, but really what the plan is to try and expand these with a focus around respiratory and frailty. Pre-Christmas, there was a real push nationally to make sure that everywhere had COVID virtual wards implemented by the 31st of December to support the possible Omicron wave, but obviously we're seeing that symptoms are slightly different with Omicron. So virtual wards, as we said, are allowing patients to receive care at home safely rather than in a hospital bed, and I'll come on to the current definition at the minute. The aim really is that you've got that clinical expertise, so that can be that isn't necessarily a consultant. It could be a consultant physio or a specialist nurse or a specialist allied health professional. So you've got that clinical expertise that has oversight and is supporting the virtual ward. You've got connectivity, so allowing the use of digital to support, so technology to help to do some of the virtual stuff as well as face-to-face, and really linking up and integrating so you can actually have that combination of face-to-face support where needed, virtual support where appropriate, and have that clinical expertise throughout the whole of the virtual ward really, so that there's timely assessments. We're facilitating earlier discharge, providing alternative admission routes, and managing patients safely outside of hospital. So this is the current definition. I'm under the impression from discussions on recent national meetings that there will be some newer versions coming out shortly, because there has been some confusion and they're just working on that at the minute. But the current definition is really, it's a safe alternative to an NHS bedded care. It's providing treatment for people who would otherwise be in an acute hospital bed, and they're digitally enabled. And it should be also, as we've said, an alternative to admission as well. So not just early supported discharge, but that admission avoidance. So there might be sort of two levels of intensity within that virtual ward. So your lower intensity patients that maybe just need some virtual monitoring and virtual support. And then there's others that may be more of a blended approach, maybe similar to some of the hospital at home models that are currently in existence, where actually you've got the sort of higher acuity patients that maybe need more a mix of virtual and face-to-face support, and slightly more acutely unwell and maybe need IVs, might need oxygen weaning, other therapeutic interventions as well. So it's really about looking at, and there's often a blended approach within the virtual ward of what that looks like. And what you'll see is the acute respiratory infection pathways and the frailty pathways are the two key respiratory virtual wards that they're looking for at the moment. What the key thing is that the virtual ward is not somewhere for monitoring, sort of proactive monitoring, long-term condition monitoring or monitoring chronic disease. And some of that proactive looking for deterioration, such as now the COVID oximetry at home, where you're obviously looking for that deterioration and trying to get someone into hospital who's got COVID earlier. So therefore, that's more the proactive care and not actually a virtual ward, even if you're monitoring. So they're trying to really have that distinct definition between the two. So you've got proactive care, and this is the sort of the vision of nationally around hospital at home and where the virtual wards sit within that. So as part of setting up virtual ward, it's also looking at how it sits in that wider context around preventative care, which we know is a big chunk for respiratory, the proactive care and proactive monitoring, then your coordinated care, and then virtual wards for those that need it, obviously ensuring that we're linking that in with existing work streams for urgent community response, same day emergency care, and looking at how we can manage those patients, but really whilst also doing more within that sort of level 1 and level 2 preventative care, but utilising the virtual wards when needed. Sorry that this is so tiny, but this is the kind of key overarching principles nationally in the guidance around virtual wards. So ensuring that we have got 7-day-a-week cover, that it is at least 12 hours a day with very clear sort of escalation pathways for out-of-hours care, and that the patients have relevant information so they know if they deteriorate or something changes who they're contacting. Making sure that there is that specialty advice, that it's time, deliver time limited interventions and monitoring, as would be in secondary care, but obviously at home, making sure that there's clearly defined quite sort of inclusion and exclusion criteria, that it is an MDT approach, that there is integration across the service, but there is that sort of clinical leadership and appropriate clinical leadership by the consultant practitioner. As we said, that could be an AHP, it could be a consultant, it could be a nurse. So it's about the right makeup of staff within that multidisciplinary team to be able to support those different elements of the virtual ward, whilst having that oversight from secondary care and support from secondary care to step up again if needed. So the current national position, so as we said, they're developing pathways for both the acute respiratory infections pathway and the frailty pathway, constantly redefining what we mean by them and making sure we've got the right definitions, but there's a link on there to take you through to the current guidance that's been put together. There's the operational planning guidance that was sent out just before Christmas, and the ambition really through this piece of work is that we can get 40 to 50 virtual ward beds per 100,000 population by October 2023. And obviously it does take into account existing virtual ward beds that may be in place, but really looking at utilising those so that we've got that capacity to improve that patient flow and manage patients nearer to home, whilst considering that sort of low and high intensity management within the virtual ward. There is funding. It's a 2-year transformation programme, but obviously we're hoping that we can get virtual wards set up so that there's support for next winter, if not sooner, and sort of building on that current burning platform that we've got with the COVID virtual wards. And I think a lot of the regions are trying to expand those and turn them into what will become that respiratory service. And there is funding coming down to the system to support that over the next year. And I think regions are currently manically trying to put business cases together for each of those virtual wards so that that money can be accessed and help to support with staffing, with technology, the wearables, whatever's needed to implement that virtual ward. This is Matt Nodder-Kim's, thank you for the slide, has been trying to put a pathway together for the acute respiratory infections. So what we're sort of, and you may have heard that there's also been some work around acute respiratory assessment hubs that would feed into the virtual wards. So this is how can we take, so not just COVID, but how can we manage other acute respiratory infections and look at triaging, and then having that hub, and that might be part of that wider virtual ward, that assessment hub, or it might be a separate service that's more primary care led, but looking and risk stratifying to see actually could they be managed in a virtual ward setting, can they self-manage with the right sort of safety netting and monitoring, or do they need to be admitted to hospital? These are some of the inclusion and exclusion criteria. Again, they can be sort of slightly, this is within the guidance and obviously always subject to clinical judgment as to whether it would be appropriate for that patient to be part of that virtual ward and whether the virtual ward could manage them effectively. So it's around suspected or confirmed respiratory infections, which will include COVID-19. Obviously, oxygen saturations, these might be the ones that are kind of the new scores and oxygen saturations might be very much clinically led as to whether or not you feel it's appropriate as to whether they can be managed outside of hospital or do need to go into hospital for further investigations. Not excluding frail patients necessarily, but whether that can be aligned with the frailty virtual wards, and I'll come on to that in a bit. But really making sure that we can manage a whole range of respiratory conditions, but obviously sort of severe or life-threatening presentations of pneumonia, asthma, or COPD or sepsis will need to go into hospital, but there's that clinical judgment throughout. So regionally, the South East region are prioritising virtual wards immediately. So they are saying actually we want to make sure that we've got frailty and respiratory virtual wards set up across the South East. The virtual ward programme will sit within the regional South East community programme, which is emerging and was part of the COVID-19 community cell. There's a group that have been formed within the South East region, so a team has been put together working alongside the AHSNs to really look at how they can support the region with the implementation of virtual wards, so utilising the national guidance, sharing learning, communities of practice, but also what do we need locally to enable that. And then each of the ICSs are currently developing, as I've said, their own plans for virtual wards. They've had to submit an overall early sort of plan of what they're wanting to do around virtual wards and what's currently in place, and then the business case I think has to be in by the end of February, and then the money will be coming down hopefully March, April time for then the implementation of the virtual wards, and more detailed plans will need to be submitted. So there are varying models. Everyone's trying to use integrated teams, looking at existing services such as hospital at home, community respiratory teams, whilst ensuring you've got that acute support. But there, as I say, there are varying models and how people are trying to do it. It's trying to make sure that it's sitting within the wider context of that hospital at home, that it's aligning with things like the virtual wards. So frailty virtual wards and respiratory virtual wards are aligning, but also with the at-home work and the urgent community response and the work streams around the same day emergency care within the acute trust. So how can that all link together and align to really provide those services? And as I said, there's the COVID virtual wards are already implemented across the whole of KSS. And some are already looking at trying to see if they can expand and take other respiratory conditions, COPD, asthma, bronchiectasis. Some are already doing that and just extended those services to take on COVID. So we're in a kind of that development phase at the moment. I'm sharing, so I'm sure Sussex won't mind because I'm doing some work and supporting them with the virtual wards at the minute. So this is kind of the Sussex overview of what we're trying to put together. We're integrating those virtual wards and having that virtual monitoring hub and sort of hospital at home core team and urgent community response that will support that lower acuity, but then having access to those specialised integrated services, the sort of more higher acuity aspect of the virtual ward as needed. And really we're talking much more of a sort of a integrated respiratory service, not just that virtual ward element. This is our agreed principles, happy to share, and it's sort of in line with the national principles really, that actually we can hopefully take referrals from community teams, from urgent community response, as well as early supported discharge into that virtual ward, where they can then have access to the various different interventions that they may need, whether it's just remote monitoring, whether it's IVs and oxygen wean, but they can be stepped up and stepped down as required, with clear discharge processes and also referral routes into diagnostics, which we know is something that needs to come together. So really, I'm going to stop there and to sort of think about how obviously this will impact on your sort of discharge bundles, both COPD and asthma, and how we can integrate those into these models, given that there might be some more early supported discharge or alternative admission and patients not actually going into hospital but being managed virtually. I'm going to stop sharing, she says, if I can come out of this and find my Teams and just see if there's any questions.
Thanks, Jo. There has been quite an active discussion in the chat while you've been talking. So I think started by Angela, some concerns about it being a sticking plaster for really what's a lack of skills across the health economy about early diagnosis and disease management. Jo commenting that we need to build that into existing pathways to fully develop an integrated respiratory service. And then Chris adding that things can become muddled and we ought really to be focusing on upskilling and upstaffing the community respiratory teams.
Completely. And I think there's a lot of work national, it's all just trying to join it up, isn't it? There's a lot of work nationally around developing guidance and looking at what's needed in terms of training and workforce development. I think it's really about, like you said, it is that integration. It's about what can we do different so we're not doing more of the same. How can we make these virtual wards actually do what they need to do, and it is about looking at the right skill mixes and still about training and upskilling the workforce, really. So I completely agree. There is some, I haven't seen it yet, I think it was being trialled over the last couple of weeks, some training being developed with HEE around virtual wards and looking what that clinical input would be. But I completely agree. I still think there's that wider issue about linking it with the diagnostics, and then that has the whole conversation about spirometry and all of those other links to diagnostics. So it needs to be something that is, I think, it's my opinion, we need to make sure that the service is actually benefiting the patients, that it's not just more of the same.
Sorry, Chris, you put your hand up.
It's only really just to I think comment, and I've been involved in a number of the Acute Respiratory Hub conversations, and my point often comes back to the same thing, and I wonder if we're overreaching and overstretching with trying to sort of take the learning from sort of COVID wards, where things were very clear and very obvious that you had a finite course of problems. Things would take 10 to 14 days to worsen and then recover, and then you could safely discharge these people off. I think that the thing that causes me anxiety is where are we going to get this significant amount of resource from? You know, it's hard enough finding a experienced physiotherapist, specialist nurse, occupational therapist to do the work that we already have. And actually, if we haven't got that staff to be able to do it, I can't see that we're going to magically get them over the next 2 years. So already I think the timeline is, I think it's fine that they've got a timeline, but it's just unrealistic. They want their cake and they want to eat it, and then they want to have another cake, not referring to Partygate in any shape, way or form here. But I think that's the thing that really frustrates me is how, you know, we've got a very limited resource and there's going to be a lot of pressure put on various people, and it feels to me a lot like we're doing this because for many years, decades, we've not sort of planned and thought through, and suddenly someone's come along with the idea is if we stick a virtual ward in, we can discharge a whole load more people and that will relieve pressure on secondary care. But actually you're going to have a lot of pull on secondary care and certain physicians and clinicians in secondary care to do that, and then a huge amount of pressure on community care to take responsibility and risks that they may not necessarily be comfortable with in very complex disease. And this is not, you know, I'm not saying that COVID's not complex, but it is relatively straightforward in terms of how it behaves. you know, we rely then a lot on people understanding what their COPD is when they get unwell, how they manage it, what their asthma is their asthma diagnosis correct, is their COPD diagnosis correct, have they got something else completely that we've not done the diagnostic test for because we still can't do diagnostic spirometry. I think there are lots of things that worry me about it. And then actually, if we nail that down to saying, well, actually, we're just going to treat the kind of, in inverted commas, well people with pneumonia, well, they shouldn't be in hospital anyway. So yeah. I'm just a bit, I'm not saying it's not a good idea, but it's just, where do we get the staff to do it? How do we do it in a safe and appropriate way that isn't going to adversely affect already really stretched services?
I completely agree. And that is the challenge, and I think this is there is money being thrown at it in the system, but that doesn't magic up the staff that aren't there, does it really?
I mean, it's the same problem with long COVID. You know, we've got loads of money for long COVID, but can I find an OT or a physio or a psychologist? Bloody hell, I can't find a psychologist for love nor money. You can give them as much money as you want. You can't find a psychologist. So I think this is what worries me.
Completely.
And on already, sorry, my last thing, and then I'll shut up. On a team that's already, like most people within this conversation, I think will have done a lot of COVID work over the last 2 years, and are probably going to be pretty stretched in terms of actually what have they got left to give. But
yeah, no.
So Joe, you've had your hand up for a while.
Yeah, no, all those points, Chrissy, are really valid, as you know. However, it's the national policy. And there's funding, and it's about the only thing there's funding for. So I think we need to think, how can we use this to the advantage of our patients? So one thing is, if we are putting people on a virtual ward, use that time to do the education, use it for a discharge bundle. You know, we can, the discharge bundle interventions is still valid for those people. But I agree, all the things say, and also use it to try and develop further where there is room for development, that integration of services, but all those points. But well, you might have an influence on national policy, but I don't.
I mean, it has
and you're
been...
right. You know, you've used COVID and just extrapolated. It's not as easy, but maybe we can use some of this funding in a way that's useful.
Can I say one other thing, and then I promise I won't say anything else. One of the other things I think that would be really, really useful, and I think we really struggle with, and if there was a kind of a strategic drive, is to get project managers who can drive this process forward. Because I think a lot of the other problems that we end up having, you know, personally speaking, is that a lot of, okay, so what are we going to do, then falls down to clinicians who then also have to deliver it. And I end up in a position, as I'm sure a lot of you guys do, that you're trying to kind of do your day job, but also be involved in developing all of these pathways. And actually what you end up needing to have is relatively experienced senior support, or you get support that comes in that is so junior or inexperienced that you end up having to redo everything and go back through everything, because the suggestions that have come up or the work throughs, you're like, well, hang on a sec, this doesn't work. So if there was a way in which we could sort of also to push the people to say, well, actually we need some kind of, not mandated, because I think every area has different problems. You know, for my patch, Slough is entirely different than Guildford, or Farnham or Rushmore. They all have very distinct issues that will need to be worked on in different ways. But actually some you know, that kind of drives to say, you know, this needs to be done by with some decent project management and project support.
Okay, and you could finish that by saying, well, Joe, you are that project support at the moment.
I am for KSS, and I'm doing 2 days a week at Sussex currently as well as their project manager, but the other 3 days will be supporting the wider system. It is challenging, and I think it's always difficult, isn't it, it feels like there is that push of virtual wards is going to solve all our problems. We know practically on the ground that isn't the case. So it's what can we do within the, you know, like Joe says, how can we maximise the money that's coming down? What can we put in place? And, you know, we are being told at national calls and on the community practice meetings and national learning events, the sky's the limit and you can be as creative as you want. So I think it's about utilising it in a way that's going to work best for each of the systems, given what they've already got in place and how that can be expanded to make some difference. So As I said, we know it's not a new concept, but the same challenges, whether you're in hospital or out of hospital, still apply around staffing and where do they come from, and the confusion of potentially, if we're linking up with the community trust as well, you know, if the community teams are leading, is they're doing frailty and they're doing heart failure and they're doing respiratory, then you're pulling on the same workforce. It has been fed back nationally and regionally. I fed that back at several meetings. So I think it's just a case of let's see how creative we can be and what we can do with it to work within the system for the patients, really. That's going to be the safest way.
And Joe, I think I'm right in saying part of the work you're doing is actually looking at what a longer term support programme might look like from the AHSNs. So actually these discussions are really helpful to inform that, because you'll be thinking about the next year or 2 years and what support might be needed.
Completely, and I think workforce is always high on the list, and there's probably going to be a separate workforce stream, but I think for this it's definitely a huge part of this moving forward. So very happy to you don't sound pessimistic at all. It's realistic, I think, and that's what we need. I think we can't be pie in the sky if it's all going to be wonderful and this is going to be really easy to do in the next 2 years. It is a longer term thing. We know workforce will be a challenge. There's the mix of it's a 2-year programme, but we need this done at pace, which is everyone keeps saying that to me at the minute. We need this done at pace, but actually we need it done safely and correctly, and it needs to be the right pathways that are in place. So yeah, the AHSNs and the region will be looking at how we can support that. So, and I'm just sort of mapping what's in place and what support's needed in each of the three ICSs at the minute. And I do see you, Chris, obviously on the acute respiratory hub calls as well.
Okay, thanks very much, Joe. Thanks for that. That's really helpful. So we're about to move into a video of Professor John Hurst, who's now the Senior Clinical Lead for NACAP. And this is actually a call from just before Christmas, from a Teams call where he gave a presentation to the workstream leads for the National Patient Safety Programme. But I thought it was worth showing an extract of it. It kind of talks about NACAP generally, but also more specifically about what the programme's achieved, just reminding us why we're all here really, and why we do the things we do.
And thanks for the opportunity for Lara and I to join you this afternoon. So I have a few slides which I will share with you, and we can go straight through onto the next one, Ash, which I think really is just a high-level elevator pitch, if you like, of what it is that we try and do in NACAP. So essentially, we're about improving the quality of care for people with asthma and COPD. That extends to children and young people with asthma. It's across different parts of the health system, so primary care, pulmonary rehab, so community services, and secondary care with adult and COPD, adult asthma and COPD. And we do that essentially in a number of ways, but it's about supporting and training clinicians and empowering patients. So over on the next slide is a little bit of where we are with NACAP at the moment, because as well as this being a time of change for patient safety, it's also a time of change for NACAP. So we're commissioned through by our commissioners HQIP until February 2023. But as you might imagine, there's a lead time in terms of recommissioning. So if we're thinking about the future of national respiratory audit, then decisions and conversations are going on right now about what future national respiratory audit might look like. NACAP at the moment is hosted by the RCP. We've got wide stakeholder engagement, and it's really great to see some of our friends and colleagues on the call from AUK BLF and Task Force for Lung Health and others today. But patients and third sector organisations are really at the heart of what we do. Indeed, we just won an award for our patient involvement. I'll drop that in there too. I told you about the suite of audits that we have, but you'll recognise, of course, that not every aspect of the care pathway is currently covered. So we don't look at outpatient care at all. We don't touch that. A lot of COPD care certainly is now delivered by community respiratory services, and we don't touch that, with the exception of pulmonary rehab. And we don't look at some more specialist interventions for COPD, like endobronchial valves, for example. The key tool here is about supporting local teams to deliver their own quality improvements. And we have a couple of ways that we support that. One is with the real-time feedback of data, which you'll have seen from our dashboards. And the second is explicit QI support. And I'll tell you a little bit more about our QI offer as well. So that for me is the core of NACAP. It's about supporting local teams to deliver better care through provision of data and QI. Of course, through linkage, and we do link to readmissions and mortality, and that's where some of these data that you've been seeing, and I'll show again in a second, come from. We are able to provide well, state of the nation reports, essentially. And those reports and the data we've provided are channeled to a number of organisations, including you guys, and you've heard from Martin at GIRFT, but also CQC and others. And so the output from NACAP is really, I would argue, critical, really, in understanding where we are with respiratory medicine in the UK. So on the next slide, despite all of that, there are some remaining really thorny problems. And so we have to look to the future to decide what we can do better. And so there are ongoing decisions and discussions within NHSEI at the moment about future audit. We've been invited to comment on that and have done so. And of course, discussions going on at the college as well about audit provision. And we expect to be hearing more about that soon in the new year. Next slide, please. But these data are still frightening, aren't they? And Martin's just highlighted them. If we look at NACAP in total, on average, almost a quarter of people being readmitted within 30 days and just over 40% within 90 days. And the majority of those readmissions, so at the bottom of the screen, are respiratory readmissions, either COPD again or pneumonia. Pneumonia is perhaps something we might want to think about again in terms of the scope of national audit. Next slide, please. I thought I'd talk next about where we have got to and what we have achieved. So we moved to national rolling audit for COPD in February 2017. And what you have on the graph on the right there is the blue line, which tracks the best practice tariff. Remember, that was tied to two things which had to both occur in the same patient. And that was about early specialist review and delivery of a discharge bundle. And the BPT setting was at 60%. And you can see that from February 2017 through to the end of this graph towards 2019, the improvement was really quite remarkable. And when you think about the number of patients being admitted with COPD in the UK every year, is 115,000 admissions, that's representing an incredible change in frontline care. That happened when we look back at how changes had occurred in previous cross-sectional audits. This change really only occurred where rolling audit was combined with QI and was combined with financial incentives. When you put those three things together, NACAP has really shown you can drive improvements in process outcomes here in terms of the BPT. Next slide, please. Of course, into that picture has been a COVID-shaped spanner. And I'm going to show you some data both for COPD, that's on this slide, and then when we get to the next slide in a second on asthma. The numbers here on the line are the number of units, by which I mean acute trusts, entering data into the national audit for each particular month. So you can see it ran between 160 and 170 prior to the pandemic. It took a hit. National audit was not mandated. Actually, I'm delighted to see that over half of trusts continue to enter data into the national audit despite the pandemic. And since that time, it's picked up. And the blue bars, in case you're wondering, are data entry deadline months. And so we do see some fluctuation. There tends to be an increase around the time of one of our data deadlines. And we're very nearly back to where we are. And that says a number of things. That says that the audit is valued, I think, by frontline healthcare professionals. It's something that they are taking part in because they see the value for that. The picture for asthma on the next slide, please, Ash, is a little bit different. So rolling audit for asthma was never quite as embedded as COPD because it started later. And so there weren't as many trusts engaged with the asthma programme. The fall off was more profound and the recovery thus far has been less complete, but as you can see is now ticking up again. So we have had some challenges around participation in NACAP, as you might expect, with frontline redeployment of staff to deliver urgent COVID and post-COVID care, and all the other things that are going on with NHS workforce at the moment. Next slide, please. So again, this is coming back to the performance on the discharge bundle. So this is bringing things right up to date. You can see from having started, and I showed you on the graph earlier, from 30% to hitting just about the 60% during 2019. Profound drop-off during the first wave of the pandemic, but a really sharp recovery, such that the latest performance figures are actually better than they have ever been, and on average nationally above the BPT target of 60%. I think that speaks volumes to the hard work of a lot of frontline clinical teams, busy delivering care, but also busy delivering QI, delivering discharge bundles. Next slide, please. I said I'd talk a little bit about our QI offer, and this becomes really important when we start to think about the momentum of NACAP and how to maintain what we've done, but also the sustainability of NACAP at this time of change. We're really proud of our new QI offer. You may have heard or been involved with it already, but the new offer is about training QI coaches who can then cascade that training locally. And that process is now being rolled out virtually through our CP education. Really successful so far. The modules are great, and there's a real team spirit occurring around that. And I think we can see great things around that. One of the things that worries me perhaps a little bit is the loss perhaps, or the adjustment of carrots and sticks. So with no BPT, what does that mean for performance, and how is that going to affect people's or trusts support for engagement in that? We do have other levers. Our reports and non-participation is reported to Trust Chief Executives and Chairs, and ultimately to CQC. Obviously, it's part of the Trust Quality Account as one of the NC and NACAP audits. So we do have some levers we can use, but with loss of BPT, there is an additional concern around that. Next slide, please. When we were asked to think about what future respiratory audit might look like, we had a number of ideas, and this is for consideration and for further discussion, but we certainly are going to be providing data at regional and ICS level to support delivery of the long-term plan. That's already in progress. We would love to extend the current primary care data, which only occurs in Wales at the moment, to the rest of England. And we think there is scope to extend the PR audit to indications other than COPD, and that would also support long-term plan delivery with wider availability of PR. And I guess the second thing is really to think about how we can better link data so that we can inform pathway change. So in other words, how does the care that somebody with asthma or COPD in primary care relate to what services they receive in the community for PR, say, and further relate to their exacerbation risk? And so by linking across audits, we think that we can add even more value to what we're doing within NACAP at the moment. Next slide, please. So that was a fairly brief summary. We're grateful for the opportunity to do that. I think the one thing that we do have to remember is that, and sometimes we perhaps forget, is that we are incredibly fortunate to have national respiratory audit for asthma and COPD in England and Wales. And without that, we would really be in a mess in understanding what the quality of care looks like. And so as we come up to think about the future of national respiratory audit, it's important to reflect on the gains that we've been making, but also how we can change and improve things even more for the future. My learning really is that the biggest changes that we've been seeing, which are changes in process outcome measures, have been when there's been a combination of rolling audit, QI support and financial incentives. And despite that, actually, hard outcomes, particularly readmissions, have been very, very resistant to change, and we need to think a bit more about that. And we need to think a bit more about sustainability, but that's why we're all here, and that's the topic for the discussion a bit later on. So I think I will stop there. You're welcome to ask Lara and I any questions, and I hope that was useful. Thank you, Ash.
Sorry. Okay. So we're just coming up to time. Are there any kind of burning questions or comments on that video before we move on? I'm conscious that we're at 3 o'clock. Okay. And then, so Siji has just asked in the chat, Joe, are there any other sessions coming up related to this? So I wonder if we could just wrap that up.
Yeah, okay, so we're just, as the Kent Surrey Sussex Respiratory Network will continue to support these programmes of work in some way. We haven't quite worked out the detail. I would say we're likely to be focusing a little bit more on asthma going forward, because we've done quite a lot of work with COPD. It doesn't mean we're giving up on COPD, but particularly linking in with the access to from asthma discharge bundles to access to biologics and diagnostics. But as we're on time, I think we should wind up for now. And have we got a next meeting planned, Sean?
We don't, so there won't be any more of these meetings now.
Right.
So that's one thing to say. The COPD and asthma work will no longer be part of the Patient Safety Collaborative, although it will now just be absorbed into the general respiratory collaborative work. So any final questions or comments from anybody? I'm conscious we didn't get a chance to go back to the Jamboard, but we'll look at that information carefully and feedback any interesting points. I can see Ellie typing something.
Hi Sean, sorry, I managed to dip back in. I was just speedily typing in the chat, but we will communicate out once we know what our programme plan is around the bundles, and if people could feed back to us whether it might be helpful to consider some form of bundle meeting in the future, we can feed that back to the AHSN as well. So thank you.
Okay, thanks Ellie. So on that note, if there's no final questions or comments from everybody, I'd just like to say thank you everybody for coming this afternoon.